Hi there, welcome to this month's iCubed. This is Dr. Alice Lee. This month I welcome back a guest I have a special bond with because we were trained in the same residency, my esteemed published colleague, Dr. Paul Beeston. Why don't you introduce yourself?
Yeah, happy to be here. I'm Dr. Paul Beeston, and I trained at Maricopa Medical Center, graduated recently in 2015 in the summer, and have been spending my first 2 years of practice learning underneath the mentorship of Dr. Lee here.
Oh, I'll pay you well later. Excellent, excellent. All right, so this month's case is actually quite interesting to me. It was a difficult case I saw. You know, we are a level 3 trauma center, so this was a call we got from pre-hospital. It was a 72-year-old trauma A patient. It was an activation, and the reason they called it a trauma A was because he was hypotensive when the paramedics arrived, and he had fallen. He had facial trauma. He had reported he had a history of CAD, diabetes. He apparently fainted from a standing position, and he struck his face. He was reportedly on Plavix, baby aspirin, and he was hypotensive. They started him on an IV fluid bolus, and his blood pressure was 58/43, the pulse of 120. He had AFib on the monitor. His room air sat was 89%. So the medics started an IV fluid bolus, and they put him on 4 liters nasal cannula. His sats were 94%, reportedly before he came in. So when he arrived, he was awake actually, and I was able to converse with him. He was in a fair amount of distress. His vitals, though, seemed to have stabilized. It was blood pressure 129/95, pulse was 115. His respirations were 18, afebrile, and his sats were actually 97% on 2 liters. On his exam, he was pale, he had cool skin, it was mottled. There was a full-thickness laceration between his brows. He obviously looked labored with his respirations, but he had clear lungs. He had a scaphoid abdomen and a little bit tender kind of throughout. What are your thoughts at this point, Paul?
Well, just knowing the system in which you work, I understand that they're trying to catch every type of significant traumatic injury.
Yeah.
When you hear someone fainting, comes in hypotensive, you obviously think about what made them faint and made them hypotensive instead of for thinking, what kind of traumatic injury did they have that caused them to be hypotensive? Right. This gentleman seems like he's on Plavix only, no anticoagulation, it sounds like.
Right.
So I'm concerned about, a potential cardiogenic type of syncope, concerned about sepsis or some type of a respiratory problem,
Yeah, those are all
whatnot.
Excellent thoughts. And, for trauma A, everybody is in there, right? Everybody and their cousin is in the room, including the surgeon, the anesthesiologist. Everybody arrives to assess the patient. Well, once we get the story that this is a syncope preceding trauma, quote unquote, we called off the trauma A right away. Mm-hmm. Okay. So I go in there, I do a really fast bedside, no pun intended, but a quick bedside fast exam. There's no free fluid. It's a skinny guy. It was easy to do.
Yeah.
So he started his workup. He was stable. He had blood pressure. You saw the pre-hospital EKG. The pre-hospital EKG showed a rapid AFib. Is really all it showed.
Yeah, some lateral repole, and did look a little bit slightly funky.
To me, when I looked at it, didn't alarm me. He was, conversant. He was tachycardic, of course, but didn't look like a STEMI of any kind that caused the syncope.
Any pre or post syncopal chest pain at all? He
didn't have any chest pain.
Okay.
Yeah. So let's talk about the ED course. He comes in, he's 8:45. He called up the trauma A. I leave the trauma room because we're getting his syncope workup started, right? We had some quick bedside studies. We get the chest x-ray, and this is what it looks like right here.
Yeah.
What do you think? Anything? So this is supine, obviously. Yeah. He was hypertensive before he came in, so I didn't really want to sit him up. Yeah, nothing really outstanding. Then a quick pelvic x-ray, our trauma docs wanted a quick pelvic x-ray, and I didn't see anything on there. Quick brain scan. So then we're putzing along. I'm doing my thing outside of the trauma room, and then I get called in. It's 9:29. This is 45 minutes or so after he gets here. He's coding in the room. Yeah. So I go in there. He's hypotensive. I intubate the guy because he's unresponsive and hypotensive and coding. We put him on levofed, norepinephrine, and I wanted to scan him, but I couldn't send the guy. He was so unstable. We were coding him until he finally had ROSC.
Yeah. What was his rhythm prior to him arresting?
I think it was AFib.
And then just PEA once he lost his pulses.
Correct. So eventually, it took forever, but finally I decided he was coding for a long time in the room after I intubated him. And so finally, it was semi-stable, sort of. I sent him to the CT scan. And it was a non-con. I just quickly wanted the scan, but he coded again in the scanner. Yeah, so I had to go in there and code him on the bed, on the CT scanning bed, So then we get him back into the trauma room. The radiologist calls me and says even without the contrast, you could see saddle P's and bilateral P's.
That's a bad deal when they can see that with no contrast. It's not good.
Yeah, and then the image, the CT scan, you'll be able to see, just sort of this hyperdense area that looks like clot on the CT.
Yeah.
So then I remember thinking about the question of TPA. And I called one of our cardiologists, Dr. Sharifi, and I've known him for a very long time. He's always been very helpful. And I just really cold called him, really, to ask him for advice for this guy. Dr. Sharifi said to go ahead and give him the TPA, the half-dose TPA. I was worried because this gentleman was a quote-unquote trauma patient. He had facial trauma, and he was on Plavix. But Dr. Sharifi assured me that neither of those were contraindications. So at that point, I think I was just very uneasy about it. I just did not know about TPA, low-dose TPA, in PEA arrest from PE. So this is a post-intubation x-ray, and unfortunately he has some rib fractures on there, is what happened.
Fluffed out just a little bit.
So I did not really know what to do. Daughter did show up in the ER. I did talk to the wife as well, and they said just to go ahead with the TPA, even though they knew there was a risk for that.
I think that's reasonable. So massive PE, someone with hemodynamic compromise, I would say cardiac arrest goes into the definition of hemodynamically unstable. So I think that's reasonable. Is it without risk? No, there's risk in every patient. Is this patient at increased risk of bleeding, side effects, and iatrogenesis from the medication? Absolutely. Does that risk outweigh the benefit? I would say no. I would also still recommend it and offer it to the patient and his family.
In retrospect, of course, that makes sense. But in the heat of the moment, I was so uncertain about what to do on a patient who had facial trauma and was on Plavix reportedly. I didn't realize that Plavix was not considered anticoagulation, at least in the setting of giving systemic TPA. So the rest of this patient's course, he was given the TPA, he was admitted to the ICU, he was on max support, vasopressors, and the family made him DNR, and then he expired 2 o'clock in the afternoon. So this was roughly 6 hours after he presented to the ER. So Paul, as you know, my screencast, I do try to focus our learning points. And the first one will be the
PIA-PET study?
PIA-PET study. So the PIA-PET study was authored by Dr. Sharifi, and Dr. Paul Beeston was one of the contributors to this article. And it's actually a really terrific article. I read through this, and I want to summarize it for you guys. This study, they evaluated the outcome of 50 milligrams of systemic TPA infused over 1 minute in patients who have confirmed PEs who are in PEA. Okay. The method was the patients were enrolled over a 34-month period of time. There were 23 patients with PEA due to confirmed massive PE. The PE was confirmed either with a CTA or with a bedside echo. Is that right?
Correct. Or bedside visualization of right ventricular thrombus.
Okay.
Oh.
Okay.
That was only in 3 of the 23 patients.
Okay. So, regardless, the point is that these were confirmed PEs. They weren't just speculative. There was confirmed PEs in 23 patients who were in PEA. All of them got the TPA during the resuscitation. Time from the start of the arrest to administration of the TPA was 6.5 minutes, plus or minus 2.1 minutes. That is remarkable how fast these guys got TPA, right?
Yes, very quick.
Very, very quick. Yeah, I thought that was amazing. The results of the study show that the patients had ROSC from 2 to 15 minutes after the TPA in 22 out of 23 of these patients. There were no minor or major bleeding. 2 out of 23 were in-hospital deaths. 20 out of 23 were still alive when they followed up at about 22 months after their arrest. The RV versus LV ratio went from 1.79 down to 1.12. The PA systolic pressure went from 58 down to 40.
Yeah, I think I had 2 patients enrolled in that study, but different outcomes on both of them. The first one was suspected arrest, although there was some question whether he had aspirated on a hot dog during the time that he suddenly went down.
Oh, I see.
We suspected PE. The family members were really wanting us to have definitive information. So he ended up getting ROSC in the resuscitation bay, was able to go to the CT scanner where a massive bilateral PE was confirmed. TPA was given to him. He ended up rearresting after the TPA about 6 or 7 times. Ended up transferring to a ECMO center where he then passed in the next couple of days. Yeah.
The discussion in this paper pointed out that in these out-of-hospital arrests, the PEAs are nearly always fatal. Only 4% leave the hospital alive. PEAs constitute 20% of cardiac arrests. 20% of cardiac arrests, and then there's conflicting results in studies involving TPA in the undifferentiated PEA.
Yeah, the last that I had read on the American Heart Association's recommendations for TPA and undifferentiated PEA was that when you group everyone together that is PEA, there really isn't much of a benefit. Technically, it should potentially help on people with a acute myocardial infarction to help them reperfuse this thrombus in their coronary artery, or maybe help these massive PE patients. But when we take an undifferentiated population, there does not seem to show any benefit. But they still kind of keep their recommendations slightly opened as far as, but depending on the history and physical and the clinical situation, you may be reasonable to use it, but it's just not a recommendation for blanket PEA.
So many years in my early career, it was always, the practice was always, you only give thrombolytics for a patient you suspect having PE in extremis. And I don't think I've ever done that in my entire career. But now with this particular study, it just gives me more confidence to make that clinical decision, to go ahead and give that TPA quickly, right from the start. I mean, these patients got TPA within no time. So the authors concluded that the administration of 50 milligrams of TPA over 1 minute in those patients with PA due to confirmed PE is highly safe and effective and leads to ROSC. And in this particular study, 20 out of 23 patients achieved ROSC with the TPA, within 2 to 15 minutes. So they felt their results were really positive.
Yeah. I do think that this study does have some limitations in that these are patients that overall were going to do better because most of them either were stable enough to undergo a CT angiogram or got return of spontaneous circulation and then able to go get a CT angiogram. These patients already showed that with massive PEs, they were able to have return to have a return of spontaneous circulation. And when this was they were getting worked up, maybe they got a CT angiogram, we saw a massive PE, we're already ordering up the TPA, and then they arrested as the TPA was being mixed or about to be given, kind of gives us this incredibly shortened window to give TPA that is really not realistic to expect, 6 minutes plus or minus 2 minutes to be given in, especially a smaller emergency department or whatnot. So it does show this rosy 20 out of 23 people surviving, but I think that this is a selected population that was brought into this study through the inclusion criteria that probably doesn't account many other PE patients that we either suspected it or we just weren't able to confirm it that still got TPA, but because they never got ROSC, they were always going to do more poorly. And
I think that's a really good point. But it makes me want to be very attentive to these patients that are out there and just be thinking about the TPA quicker than in my patient, this index patient. It's sort of like the endovascular patients for acute thrombus, acute CVA. You just have to keep your eyes out for those. You want to get those patients diagnosed quickly, just like with this one. With this particular patient, thinking about it, how could I have improved his care? How could I have increased his chance of survival? For learning focus number 2 in this particular case, I want to take a look at Bedside Echo. Now, I did a screencast with Dr. Menya a few months ago, and I had a patient at that time. He was a young guy, I think, who was on testosterone, and he had very stable but bilateral PEs.
Nice.
So I was able to go to the bedside and do a bedside echo on him. So on the left is that patient. That was that gentleman with the PE on testosterone. And then on the right is a normal the normal parasternal long axis. So if I had put a probe on this patient's chest, I might have been able to see either a clot or suggestion of a massive PE, and then would trigger that whole cascade of thinking about TPA.
Yeah, definitely looking for right ventricular dilation. I think that the parasternal long axis is great because you get a good view of the LV as well as ejection fraction. I like to also get a good 4-chamber view or an apical view. It's much easier for me to try to get into view both ventricles, and it's easier to do a chamber comparison size from that view.
That's true.
And so that is kind of my money. What does the RV look like compared to the LV? And certainly we have to exclude patients that have pulmonary hypertension, cor pulmonale, other reasons to have chronic RV dilation, because not all RV dilation would be acute. But if they don't have any of those other medical conditions that would result in RV dilation, and you see new RV dilation, then your index of suspicion for massive PE or submassive, if they're hemodynamically stable, goes way up.
Yeah, that's true.
I just measured them end diastole, and then you can just get a ratio, like a right ventricular to left ventricular ratio, which usually should be like about 0.8.
Are you talking about a 4-chamber apical view? Okay.
Yeah, because the RV should be about like 80% the size of the LV in diameter at baseline, but obviously with large PEs, they're usually not only not smaller than the left ventricle, they're usually bigger than the left ventricle.
Yeah.
And sometimes just eyeballing it, you can look at it and say, whoa, this right ventricle is huge compared to the left.
So in this previous patient, the parasternal lung, it was really obvious that the right ventricle was dilated compared to the left ventricle. And then if you compare the normal versus the PE study, you can tell. It's just so obvious. So anyway, in this particular patient, it's taught me that next time I'll keep my eyes open and be much more, I think, quick to get a bedside echo to see if there's really any suggestion of a PE or right heart strain.
Yeah. My practice now is if I'm thinking PE or if I have a really high index of suspicion, I'm confirming it. We can go ahead and pull the TPA. We can pull the TPA. Without arresting them, I'm still going to give someone that is hypotensive TPA. I may give it to them not all in 1 minute, maybe 10 milligrams, and then 40 over the rest of a certain time. At our hospital, we have a protocol to give it under 2 hours, but giving the first 10 milligrams in the first couple of minutes. But if the patient decompensates or worsens, it all goes in a minute.
Really?
Yeah.
Oh, I did not.
So you have your treatment, how you administer that changes if the patient changes and they code. But that happened to be the second patient that I had enrolled in this study, which was a pre-hospital patient who was respiratory distress, short of breath, hypoxic on room air. She came in obtunded, hypotensive, hypoperfusing. She had no kind of history of trauma, but I looked at her heart and saw just a really large right interventricular clot that is just swirling around there. She still had pulses, but I saw it and said, this lady's got to have a PE. So let's order the TPA. So we order it. They're mixing it. They're trying to get it ready to administer. Then she arrests. Her time from arrest to TPA administration was like less than a minute.
Wow, because you already had it.
Because we already had it. We're already planning on giving it to her. And she ended up getting ROSC within just 1 or 2 minutes, and then she ended up doing well and had a full neuro recovery from her just very brief arrest.
That's great. Wow, that's fantastic. Well, Dr. Beeston, thank you again for gracing this screencast with your presence, my esteemed colleague. So thank you everybody for watching and listening. I hope that this case was instructive and that you've learned something from us. We'll see you next month. Bye.
Bye.